Hello and welcome to another episode of Boundless Body Radio. I am your host, Casey Ruff, and today we have another awesome guest to introduce to you now. Dr. Greg Dennis is a board-certified physician in family medicine. He is also certified in age management medicine. He met his wife, Lydia, who was also a practicing doctor, back in medical school in Kansas. He has now been practicing for almost 14 years. Dr. Dennis recently began to appreciate the harms of the standard model of healthcare and will be making a transition to direct primary care. He has also started a podcast called FitRx, which brings us the latest advice to optimize health and fitness. He practices what he preaches and is a great example of what a healthy life can look like. Dr. Greg Dennis, welcome to the show.
Good to be here. Thanks for having me.
Absolutely. So when did you know that you wanted to be a doctor?
Well, I wasn't one of the more traditional, medical students or pre-med students. When I say traditional, a lot of the people that go into medicine are kind of academic, like my wife was. She was very academic in high school. I was not. I preferred having fun and sports and that kind of thing. Even going into college, I was not. I would not have termed myself academic. So it took me a little while to grow up. And I started working as an EMT. Eventually went on to get my paramedic. And so it was through that I, obviously we would go in the emergency room all the time, and I got to talking to all the ER doctors and just thought, hey, this looks pretty cool. And kind of began making up for lost time, I guess, in college. And so probably, about the time people are graduating college, 2023, something like that is when I started that journey, realizing I wanted to go there. And then it took another 3 or 4 years after that. So I was in my late 20s, but when I finally started medical school.
Wow, interesting. That is a little bit late. What was the reason that you got into, what drew you to be a doctor if you were already in the medical field?
Yeah, just I think I wanted to kind of do more than what I was doing. Like I said, working as an EMT / paramedic, it kind of introduced me to the medical field, and then just getting to know a lot of the emergency room doctors. I had also befriended an orthopedic surgeon, and I just felt like I wanted to do more in my career. Obviously, everyone who goes into this sounds kind of cliche, but they're going to say, oh yeah, I wanted to help people. So of course I wanted to do that. And I just wanted to challenge myself, kind of academically and do more or do as much as I could to try and help people.
Love that answer. Did you always know that you wanted to be practice family medicine, I guess?
No. So with my EMT background, I actually went into medical school with the idea of going into emergency medicine. And then once I got into medical school and I started rotating in emergency medicine, I just realized that wasn't for me. And for various reasons. And so that kind of led me to family practice, because really in family medicine, you get to do a little bit of everything. And obviously you get to know the families, and, you get to know the kids. And so that's kind of the cool thing about family medicine. I even did obstetrics for a little while. So I delivered the babies, and still to this day, I see a lot of the kids that I delivered, 13 years ago, 14 years ago. And
that's
still
so cool.
Yeah. That's the fun part about family medicine. So, I see their parents and then their parents. And so that's the cool thing about family medicine.
Was the pace any different, like switching between EMT and paramedic to the family practice?
Yeah, it's apples and oranges. I worked in a kind of a small town EMS service. So it was hurry up and wait. We'd sit around, we worked 24-hour shifts like a fire department. And so, you could sit around all day and not do anything, and then, be really busy for a couple hours. And so you just never know. It's a lot of unknown, and it's a lot of course, getting up in the middle of the night. And the shift work is terrible. I feel sorry for these, firemen and stuff now. And of course now I'm in a, regular office setting Monday through Friday, although it's busy, but the hours are contained. So yeah, it's just a lot different.
Interesting. So that was, let's see, 2007 that you started practicing. Do I have that correct?
Yeah, that's when I graduated residency. Yes, sir.
Gotcha. So you got into the industry to help people and you switched over to family medicine and certainly have helped a lot of people. But what did you start to learn about the medical system?
Yeah. So yeah, it's a big topic. So when we get started, and I think most people are this way who go into medical school, you're taught a certain way to practice, and and you don't really question that, because why would you? That's the way they've been doing it for a long time, and your professors are really smart, and so why would you question this? And so as I graduated residency, started my own kind of family practice, I practiced what we call the standard of care. Okay. Or I would also refer to it as evidence-based medicine, which unfortunately has to do with prescribing a lot of medications. And so I'm sure listeners out there can relate. I mean, if you go to the doctor, you're probably going to get a medication. I mean, if you have diabetes, you're going to get a medication. High blood pressure, if you're depressed, I mean, whatever. I mean, you're going to get a medication. That's what we do. We prescribe medications. And unfortunately, that's how we're taught. And so, the mark, it seems like today, of a good doctor is knowing what the right medication is to prescribe. Well, and I did that. I did that to the T for many, many years. And I prided myself in, practicing, quote, evidence-based medicine, or this standard of care. And when patients would question me, I would say, I always come back to that. I would say, well, I'm the doctor, I practice evidence-based medicine, and here's what the study shows. So therefore, shut up and take this medicine. I didn't say it like that, but I mean, more or less, that's what we're doing. Well, over the years, I don't know, it was several years ago, I kind of had an epiphany. I had this light bulb moment that, you know what, these patients aren't getting better. And I have a huge panel of patients. I have almost 3,700 patients right now.
Wow.
Now I'm leaving this current model, and we can talk about that in a minute, but seeing that many patients over the years, I've seen a lot of different, obviously prescribed a lot of medicines, seen a lot of different, a ton of people with diabetes and all these different chronic diseases that we deal with. And one day I just realized, these patients aren't getting any better. I'm doing everything I'm supposed to do, and I'm meeting all these things that we're supposed to check off the list. And on paper, they look a lot better. So their cholesterol looks good. Their A1C looks good, which that's a marker for blood sugar. Their blood sugar looks good. I mean, everything looks good. And of course, they're on all these medicines to help with those markers. But the patients are still sick, and they're still dying of heart attacks, and they're still miserable. They're still obese. They still have arthritis. They still have these autoimmune issues. And so, like I said, I had this light bulb moment of, okay, what are we doing? Like, I'm really not making patients any better. Like I said, yeah, their labs look better, but they're not any better. And so I just kind of took it upon myself to take a deep dive in literature, and not necessarily the standard medical journals, because you're really not going to find it in there. But as I begin to look into things, I begin to realize or question a lot of just the standard of care, thinking, man, I don't know that we've been doing this right. And so the more I looked into it, the more I realized how bad a job the standard, medical care is doing, the standard healthcare. And so I really got into nutrition and just, studied nutrition a lot. And unfortunately, we're not taught a lot of nutrition in medical school. I mean, most doctors know very little about nutrition. And I just started researching how to get healthy, and how to make people healthy. And what I found is much of the time that has nothing to do with prescribing medications. And so the more I've gotten into that, the more it's made me excited to be a doctor. I mean, I'm more excited now in my career than I've ever been, because I've realized I can actually help people. I can get people off medications. I can reverse many of their chronic diseases, but it's through lifestyle. It's through a certain way of eating, through fasting, through, different things like that. And it's not through medication.
That's so interesting. Describe what a problem that can be personally for you. I mean, if you find something that works but isn't necessarily included in the standard of care, isn't that a huge problem? Isn't that very risky for you in your career?
There is probably a little bit of liability involved. I think you have to really educate the patient to kind of protect yourself from that. And you have to get the patient on board with what you're doing. And you have to document, hey, we discussed these options, with the patient. So there's probably a little bit of liability risk just because you are going against a little bit of the standard of care. Where I find the biggest problem is with specialists, because patients, they want to trust their doctors. And so if they're getting conflicting information, then a lot of times they don't know who to trust. For example, if I'm recommending a certain type of a diet, so let's just say we're talking about a diabetic, and I'm going to recommend a high fat, low carb diet. And then they're going to go to their cardiologist, and their cardiologist is going to say, well, that's the worst kind of diet you could be on. Why would you want to do that? And then so the patient comes back to me and he says, well, my cardiologist told me not to do that. So I'm not, I'm not going to do that because he's the cardiologist and he knows more than you do. So that's a little bit of a struggle. Most of the primary care doctors that I talk to, about this stuff that I'm learning, they just, some of them probably think I'm crazy. Some of them think it's interesting. But they're so entrenched in the way they've been practicing. A lot of them, just aren't going to change much. They don't really care. They're just going to do their thing. Every now and then, we'll get some converts, just like what happened to me, to have the light bulb moment. And that's actually one of my motivations in the podcast that I do is I want to educate the public and educate my patients, but also want to educate doctors about, hey, there's a better way to do things. But yeah, it's more the specialist that becomes an issue. And I've gotten phone calls from cardiologists that, hey, why, how come you don't like statin medications, which is cholesterol medications? How come you're wanting to take these patients off? And so, I have to have those discussions.
Gotcha. So it just sounds like more disruptive, or I guess like challenging to get people on board versus being like a risk for you personally. Is that fair to say?
Yeah. And it's confusing for the patients. Like I said, because I'm telling them one thing. I'm like, hey, we can reverse your diabetes. We can get you off these medications. And then they go to their specialist and, they get conflicting messages. And so it's confusing for the patients.
Gotcha. And it's also difficult in the model with the time that you have, right? Like for me, I'm a trainer, and so I get to see somebody for, 30 minutes or an hour, whatever they want to do. And that could be once a week, twice a week, 4 times a week, whatever that person wants to do. And so I have tons of time that I can spend answering questions. I'm counting to 12 poorly, according to most of my clients, but I'm counting, reps and designing programs. But I can also, talk about diet and shoot ideas back and forth for an hour every single week for as many weeks as that person wants to train. And that's not necessarily the time that you get with your patients. Is that correct?
Yeah, absolutely. So I'm currently in corporate medicine, and what I mean by corporate medicine is I work for a big corporation. Most doctors do. Very few family practice doctors today, are in private practice, and even those that are still in the insurance model. And in that model, really, the only way to get ahead is they have to see volume. They have to see a whole lot of patients, and especially in primary care, because we don't do a lot of surgeries and stuff that are kind of high dollar type procedures, and so we just have to see a lot of patients. And so yes, the current model that I'm in, I mean, I'm allotted 20 minutes total for patients, but that also includes check-in time when the nurse is checking them in. So by the time I get in there, I mean, if I'm spending more than, usually 10 minutes or so with the patient, then I'm running behind. And, so you're absolutely right. I mean, it's difficult to make a lot of changes in the current model that most primary care doctors are in.
Wow, that's really challenging. Was this the epiphany that you had? Was this more related to your own personal fitness, or was it more related to your patients? I know you said that you were seeing that your patients weren't getting better, but were you personally noticing anything with your own health?
I've always been pretty healthy. I've always been into fitness and working out. So to answer your question, I would say a little bit of both. I mean, as I'm getting older, I want to optimize my health. I want to stay healthy, and so I started researching a lot of this stuff for my own benefit, just again to kind of optimize my health. And so there was some of that. I didn't have any major health problems, but again, just wanted to be as healthy as I could. And then the fact that I just noticed again that patients just really weren't getting any better doing the standard model of care.
Let's break down some of the things that you discovered. What were parts of the epiphany? You mentioned nutrition. I'm sure exercise is part of that. What things did you learn that surprised you, I guess?
Well, diet is the big one. I mean, as I'm sure doing fitness and nutrition counseling, that the standard American diet is probably one of the worst things that we could do for people.
Terrible.
But unfortunately, I mean, that's still the way most people eat. And so just discovering, all the negative health effects that the standard American diet has. And so that was the first thing I really started studying a lot, was nutrition. And then I discovered that if we get away from the standard American diet, and it's just completely opposite of what they've been recommending all these years. And of course, if you look at the traditional food guide pyramid, they recommend these grains and carbohydrates and fruits and vegetables being on the bottom, or the majority of your calories. And so we really need to flip that food pyramid upside down. And of course, fats have been vilified all these years. And so, I discovered that fats are not bad. And in fact, for many people, I mean, I recommend a higher fat, lower carb type of a diet. And when people have been inundated with this message for so many years that it's just hard to switch their mindset. But when they grasp that concept, man, they can just make huge strides in their health. So yeah, so nutrition was a big one. And I realized also that obviously the standard American diet makes people fat, and it causes people to be insulin resistant, but it also causes so much inflammation, and which causes arthritis, which leads to autoimmune disease. And so by cutting out a lot of the inflammatory type foods, we can get rid of pain arthritis, and again, in many cases, autoimmune disease. And so the power of nutrition was probably the biggest discovery that I had, and how far that can go in treating chronic diseases.
Okay, hold on, Dr. Dennis. Now, are you telling me that the healthy whole grain cereal that I have in my cupboard, it says heart healthy right on the label, is not heart healthy? It's not good for me?
That would be correct.
Dang, I'm gonna have to throw it away. When we talk about the standard American diet, what are some of the features of the standard American diet? I kind of just imagine wandering through the middle part of, I guess, a grocery store and just looking at the aisles. And again, there's all these things that are screaming at me, telling me that they're healthy, but they seem like they come in boxes and bags and cans. And I mean, what are some of the components of the standard American diet that we were told we needed to eat besides the grains and the fruits and vegetables and all that other stuff? Like what things make up the standard American diet and make it so bad for us?
Yeah, well, the grains are a big one. And the grains of today are not the grains of, yesterday, if you will.
That's a great point. Yeah, that's a really, really good point.
Yeah. So yeah, grains are terrible. And you just said it. I mean, the things, that say, the oats and the cereals, the Cheerios, that say heart healthy, they're not heart healthy. And so all of these things, and I know we both interviewed Dr. Bickman.
He's the best. He's the best.
Yeah, he's fantastic. But, and he studied insulin and the effects of insulin on chronic illnesses. And so what people need to understand is that, a lot of these carbohydrates, whether they're quote good carbohydrates, okay, they increase insulin. Okay. Now, if you're an athlete and you exercise a lot, that may be okay. Unfortunately, that's not a lot of what I see. And there's a very high percentage of people, especially, in my patient population, that are insulin resistant. And so whether they're eating good carbs, bad carbs, whatever, it's increasing their insulin. And so what we're seeing today is a chronic high insulin levels, which is leading to the a lot of the chronic health problems, as Dr. Bickman pointed out. And so to answer your question, all the things that are supposed heart healthy, unfortunately, a lot of them are on that list of their carbohydrates that increase insulin levels, and even fruits. I'm not saying that all fruits are bad and you should never eat fruits, but I think fruits are a little bit deceiving, and we've put that message out that we need so many servings of fruits each day, and everybody thinks that fruits are healthy. And that's not necessarily the case. Fruits raise insulin, and in some cases, fruits are even worse. I mean, they have to be converted in the liver, fruits can really increase your insulin. And one of the doctors described fruits as nutritional porn, and I love that because they look really enticing, but can do a lot of damage. And so yeah, and the things that have been deemed not heart healthy, of course, are the fats and saturated fats and animal foods. And so what we're finding is those are the very things that probably can optimize health. And it's so hard to get that message out there that I would rather somebody eat full fat butter or lard than I would for them to eat, a fat-free cereal, that's supposed heart healthy.
I made a post about a year ago that I I didn't make many friends with this post, but I talked about apples, and there was a natural apple tree that was growing nearby, and I showed, the size of what this apple looked like. It was pretty small, and the fruit itself was, it was kind of sweet. It was a little bitter, and after one, you eat one, and you kind of get your fill of apples. And I contrasted that with the apples that I can go buy at a major store, and they come in this cellophane wrapping, and they're softball sized, and they're so sweet. Like, they're really, really sweet. And I can only pick the apples off the tree for a month and a half, maybe, and then, like, goodbye apples. There's no more apples. Yet I can walk into the store 365 days a year, and I can buy one of those softball size apples, which came from who knows where and sat in who knows what silo for however long. Most apples are 6 months to a year old by the time you get to them. And most people, we've just grown up with that. And so that's what we think of as fruit. So, and you mentioned grains being something that we've modified. Fruits also are nothing like what they used to be.
Yeah, for sure. And, I tell people this idea that, we need fruits and vegetables 365 days a year. That's preposterous. I mean, there's not very many areas in the world where you have access to fruits and most vegetables 365 days a year. And especially I live in the Midwest. And so what I tell patients, I mean, we have pretty cold winters. And, I say, okay, look, even 100 years ago, 150 years ago, how much fruit were people eating the month of December? I mean, they weren't eating fruit,
That's right.
So, we didn't have a Walmart. They couldn't, they couldn't go 365 days a year and buy apples and oranges, exactly like what you're saying. So yeah, this idea that we need, X amount of servings of fruits and vegetables 365 days a year is crazy.
Yeah, I love that you brought up the location as well. I think there's some really interesting connections between, the vitamin D you get with the sunlight and how active you are, and how most fruits and vegetables grow near the equator. And those people can still be healthy and eat more of the fruits and vegetables, but they are getting a lot of sunlight. They are getting a lot of activity, and they can handle that really well, where, in the farther extremes of the planet, it's going to be a lot harder. And availability, again, is just, it's not like you can go to the store and buy them in a more natural setting. If they're not growing, you can't eat them. So the only other choice you have is to do what you said, find really nutrient-dense animal products that you can have and get your fill of that, because you're not going to get it all the time. Is that correct?
Absolutely.
You mentioned saturated fat. That's the fat that is the most villainized, has been villainized from the beginning. We go back to the 1950s, 1960s. Dr. Ansel Keys first starts out by saying fat is bad for you. The connections between fat and heart attacks has never been established, so the attention turns to saturated fat. Can you tell me a little bit about why that happened, and what benefits we can get from eating, at least including some saturated fat in our diets?
Yeah, for sure. So I'm certainly not an expert on the history, but I know you mentioned Ansel Keys, and yeah, it started with him, and his research, if you kind of dig into it a little bit deeper, was very flawed, and he really cherry picked the data. So he looked at quite a few different countries. I want to say it was 11, but like I said, I could be wrong. It's been a while since I've read that.
I think it was 22 different countries that he had reliable data on. It's ridiculous.
Yeah. And so the data that didn't fit with his narrative, he just left out, and to fit with what the message that he wanted to get out there. And so, what's funny, I mentioned this in my fat burning lecture, which was one of my first podcasts, but I have a graph that I show on a PowerPoint slide, and people couldn't see it in my podcast, but in the 1970s, it's a fairly flat line as far as the increased rates of obesity. And in the 1970s, right about the time they came out with the food pyramid, which is when the government got involved in telling us how to eat, I mean, obesity rates it just starts going up. But anyways, it's just an interesting point there. But yeah, so it was political. Also, there was a lot of influence, on the grain farmers and stuff. And when George McGovern came out and he had he proposed this idea of eating that fats were bad and that we should be getting all these grains and all this stuff, and unfortunately it just kind of stuck, despite evidence to the contrary that and now I say many people, there's unfortunately still a lot that kind of live in the dark, but there are more and more people realizing that how flawed that data was and that fats aren't necessarily the enemy. So saturated fats, especially, we know now, it sounds like that they A, do not make people fat. B, they're not going to adversely affect your cholesterol, and that's a whole nother topic. When you eat natural animal fats or saturated fats, they're very satiating. And so, and fats do so much in our body. Cholesterol, again, has been vilified, but cholesterol has served so many purposes in the body. And so when we take away fat, specifically saturated fat, not only are we going to be hungrier, which is going to lead us to eat more of, what I call the crap carbs, but we're not getting a lot of that good nutrition, we can get from fats.
I love that. I want to highlight a few of the things you talked about. And first and foremost, I have to tell the listeners, if you have to stop this podcast right now, do it and go to FitRx and look up the 2-part series that you did, Dr. Dennis, talking about fat burning. That was an absolute clinic. I couldn't have said any of that better myself. You did an amazing job telling people how to burn fat. So please, listener, go and listen to that series of podcasts. They're about 35, 40 minutes each. And they're masterfully done. That was such a great explanation on what most people want to do, which is burn fat. They've got too much. They don't like it. It jiggles and they want it gone. And that is a fuel source. That is energy that is on the body that can be used and gotten rid of. And most people are seeking that. They think they want to lose weight, but they really just want to burn fat. And so you did such an amazing job highlighting how to do that. And so for the listener, FitRx, that podcast, 2-part series, go hit that up. If you have to come back to this later, go and do that because that's incredible. You did a really nice job with that. I want to say also that just for the listener, if you're confused about what saturated fat is, a really easy way to know and identify what saturated fat is saturated fat will generally be solid at room temperature. If you cook, a little bit of bacon and you leave the pan out, you come back an hour later, you'll notice that it's kind of solidified. That is what a saturated fat is. And that means that fat is really stable. It can be reused. It can be cooked again. Grandma always had that can of bacon fat that she would cook with on the stove. And don't you think that so many people look at a steak and look at the fat and think oh my God, there's so many calories. I can't eat that many calories. And there's so much fat, and the fat is going to make me fat. And so they avoid those foods and go towards what they think is healthy, which is maybe like a salad or like pasta or something. But then they're always hungry. They're never satiated. I love that you use that word because satiation is such a different word than fullness. I can get full on a plate of a salad with some chicken breast, but in 2 or 3 hours, I'm going to be starving. And that is very different than satiation. Would you agree with that?
Absolutely. Yeah. And I think we need to get away from calorie counting. And what I tell patients all the time is we just need to change the fuel. So change the type of fuel that you're eating. So more fats, less carbs. And so don't worry so much about calorie counting because I don't really think that's got us anywhere or helped us out much. But it's more just about changing what we're eating.
I absolutely love that. We get questions all the time about fasting, and it's something that you have already mentioned. It's a practice that I love, but a lot of people, they want to try fasting, but they're so hungry all the time. What are some steps that people need to implement to prepare to even attempt fasting without making it completely miserable for themselves?
Yeah. And so fasting is one of those things. And, you were asking me about all these things I've discovered, in my journey along this, nutrition was one of them. But fasting, I have discovered as a clinician, is such a powerful tool. And what's nice about fasting is it's free and it can do so many things to heal the body. I mean, I did a whole podcast on fasting where I interviewed somebody, but
Jen Stevens, is that right?
That Jen Stevens, yes.
Yeah, awesome.
Yeah, she was great. But fasting can not only decrease your insulin levels, it can make your insulin work better, meaning increase insulin sensitivity. It can decrease risks of cancer. It can just heal your gut. So many things. Just a quick story. My dad, who's 80 years old, he's had gut problems for, 20 years. And of course, he's seen gastroenterologists, he's seen specialists, and of course, they put him on medications. Nothing ever worked. He just continued to have, these gut issues. And the only thing that reversed that was when he started fasting. So he just does some intermittent fasting, and after 20 years, his gut problems went away. So
that's amazing.
Fasting is just extremely powerful. Not only for weight loss, but just for general health. And I fast. I'm a pretty lean guy, and I intermittent fast just for the health benefits of it. But to your question, as far as getting started, you're right. I mean, I have patients all the time say, I can't fast. I get hangry. I get irritable. Blah blah blah. So start slow, is what I say. So I tell people if you finish eating at 7 or 8 o'clock at night, which you should never eat right before you go to bed. If you feel like you need breakfast right away, extend that out a little bit and try not to eat until maybe 10 o'clock in the morning, 9 or 10 o'clock in the morning. So if you do that, you just went 10 hours. Okay. And then once you get used to that, extend that out to noon. So if you eat at 7 or 8 o'clock at night, you skip breakfast. You don't eat till noon. You just went 16 hours. I mean, when I tell people to fast for 16 hours, that sounds like a long time. But if you're sleeping, you just skip one meal, you just went 16 hours. So that's a really good place to get started. And I tell people to do that, 2, 3, 4 times a week. I mean, you can do it every day if you want, but especially getting started, just do that some. And then I really encourage, once your body gets used to that, then once a week, do a 24-hour fast or close to it. Again, you just got to kind of ease into it. Don't just jump into an extended fast, but ease into it. And then I also recommend people maybe quarterly to do what I call an extended fast, which is about 72 hours. Again, don't start off with that, but as you're used to these shorter fasts and as you get used to these 24-hour fasts, we'll occasionally try a longer fast. I mean, you just get so many health benefits from it.
I love that. That's really great advice. I think that most people, if they really think about it, they're actually not terribly hungry in the morning. And so I think that's a really great place to start. I'm glad you brought that up rather than try to do it, at night or try to force it. Just start in the morning. Do it when you wake up and, maybe you're a little hungry, but maybe you can kick the can down the road a few hours and you'll be fine. And that's a really great place to start. And I agree. I think benefits of fasting for even 16 hours a day, and then you can eat, however many calories you want to eat in the time window that you have. That alone is super effective. So I think that's really great advice. And I love that you made it so easy for the listener to be able to start. I think I totally agree with you. I think it's one of the most beneficial practices for health and body fat control and so many other things. So I'm really glad you brought that up. What have you noticed with the people that do the more extended fast with the 72 hours? Do they get multipliers higher hunger levels for every day that they fast? Like, is day 2 2 times worse than day one? Is day three times worse than day one? Like, what have you noticed with people that go long?
Well, I don't have a lot of people, unfortunately, that take me up on that extended fast. But the ones I know who have done it will say that day two seems to be the hardest. Day three is not so bad, and I've even had some. Actually, a good friend of mine did a 5-day water fast, meaning nothing but water. He did really well up until about that 5th day where he was just kind of feeling weak. So yeah, I think the day, well, you know what, it seems to kind of vary. I mean, some people will say once they get through that first 24 hours, it's pretty easy. And then I've had others say, yeah, kind of that towards the end of that second day gets a little rough. So I don't know. It tends to kind of vary a little bit.
Yeah, I agree. I think that second day for most people is the hardest. I had a client once who was trying to lose weight, and he was doing weekday fasts. And so he would drink coffee and he'd drink water, but for the most part, he wouldn't eat. And the second day would be the hardest. But he would come in and strength train on Friday, like 5 days into eating next to no calories. And his strength would be like off the charts. It's so counterintuitive. You'd think he'd be crawling in, and not being able to do anything, but his energy levels were so high because the body was accessing the fat that was already there. And that's what people don't understand is the difference between eating less calories, which drops your metabolic rate, versus not eating or fasting or trying a ketogenic diet where your metabolism actually increases. I mean, I noticed that so many times over the years when I would actually measure people's metabolisms, and the people that had low ones would do diets, and the people that had high metabolisms would leverage fasting or low carbohydrate diets, and they saw amazing results. It was way cool to see.
100%. Yeah. And I talked about that in my fat burning lecture that, that's why I'm not a fan of the low calorie diet. Because just as you said, it decreases your metabolic rate basically. Whereas ironically enough, fasting does not do that, but when you eat the lower calorie, it does.
Yep. Yeah, totally so counterintuitive. I want to go back to your practice. You described doing corporate practice. Your wife does something different. So she's doing direct primary care. Tell us a little bit about that.
Yeah, so direct primary care is kind of a unique concept. It's kind of going back to the good old days. And so we get out of the insurance model of healthcare. And so people pay a monthly membership. And I tell people it's like a gym membership. So you pay a monthly membership and it's very reasonable. And then you can see your doctor as often as you want. You can text your doctor. So if you have a rash, you text it to them and say, hey, what do you think? And so a lot of times you don't even need to come into the office. And, the doctor will say, hey, I'll call you out a steroid cream or whatever. And you take out all the middle people. So the patient is paying you this monthly fee. And so if they need labs, then we get labs at cost. And a lot of times we even dispense medication out of the office that we're giving the patient at cost because we're not pharmacists. So we're not trying to make money on medications. We're not trying to make money on labs. And so patients can really save a lot of money. Kind of the ideal scenario in a direct primary care setting is somebody has a high deductible or catastrophic type plan, which we always encourage because if somebody has a car wreck and has to be in the ICU for a month, I mean, you want some kind of catastrophic plan. So you have that, and then you use your monthly fee for direct primary care for everything else, and that should take care of the majority of your healthcare needs. Where your primary care, where your urgent care, all that stuff. So within that model of care, the idea is that you can take better care of a smaller population of people rather than like what I'm doing now of, I've got 3,700 people, and in a direct primary care setting, a lot of times we cap out at 500 or 600. So you get to know your patients a little bit better, and you're not seeing 20, 25, 30 people a day. A busy day for my wife might be 8 patients a day. So you can spend an hour with your patients talking about nutrition and all these things that we've talked about. And so it's just a little bit more, intimate with your patients. You get to know your patients a little bit better. So it's a pretty cool way to practice.
That's super interesting. Oftentimes in podcasts, my favorite episodes are where couples work together and they interview each other. And you interviewed your wife, which was my favorite episode. And that's saying a lot because I love all of your episodes. They're really great. But the one that you did with your wife was super interesting. And you guys described what the difference was in the day in the life of each of you. And you've kind of described, how many patients you have to see and what your day looks like. What does her day look like by contrast?
Yeah. So, one, she gets to make her own schedule. It's her business. And so I think she allows an hour for each patient. And now she may not spend a full hour, but she has a full hour. And so if a patient is complicated, you have the time to do that. Whereas in my setting, if I have a complicated patient, it's going to throw my whole day off. And so, again, a busy day for her might be 8 people. Busy day for me is 25 people, 30 people, something like that.
Wow.
So
interesting. Is it financially viable for both of you to be doing the same thing? Like, is that putting all of your eggs into one basket, so to speak, or will you guys be able to pull that off?
Well, there's no doubt that we'll take a little bit of a hit. So I'm moving over to the direct primary care model after the first of the year, and one of the nice things about corporate medicine, as it's got a lot of flaws, but I do get a good salary. And so leaving that and kind of going out on our own, we'll take a hit initially, but we're looking forward to opportunities in the future, and then we'll see. We'll be fine, but it's going to be different.
Well, I'm so glad you guys are doing it. I think it's such a cool leap of faith, and I think it's the right thing to do. And I, for one, I'm thrilled that you guys are doing it and setting that example. So good for you for taking the risk. I love the concept, and I think that's a really great way for us to move forward and kind of change the system a little bit. So
it's a great way to change the system, and it's a lot of doctors are hesitant to do it because they have what we call golden handcuffs, which is, they're in corporate medicine like myself. And again, they get paid pretty well, and it's hard to leave all that. It is. They have the security of a good salary job with benefits. But there are more and more doctors getting frustrated, with the system, and especially people like myself who kind of go a little bit against the grain in the way that I like to practice. This model just fits what I like to do a little bit better.
I see what you did there, against the grain. I see what you did there. That was good.
Oh, there you go. Yeah.
On the cover of your podcast, we see you, and you're not like flexing or anything, and you've got a shirt on, but you can see your veins have veins. And you mentioned that you were a pretty in shape dude and pretty lean. What do you do for your workouts?
Oh, wow. Yeah. So I've always enjoyed working out. I've done a little bit of everything over the years. Now I do just kind of traditional weightlifting a couple of times a week. I am involved in CrossFit. I don't do CrossFit every day. I'm an aging athlete. And so CrossFit's kind of on me to do regularly, but I do like that occasional HIIT type of a workout, and I like the variety. So I work out, again, traditional weightlifting, probably 2 to 3 times a week, maybe do CrossFit 1 to 2 days a week. If it's a pretty day outside on the weekend, I may go for a short little 2 to 3 mile run. And then I do other crazy stuff like, getting the cold pool. Matter of fact, I was just in it right before I got on with you.
I love that.
I'm surprised I wasn't shivering. I think because I only stayed in about 3 minutes. A lot of times when I'm in 5, I'm just like shaking uncontrollably for about 30 minutes.
Oh, wow.
And I've got a sauna. So I get in the sauna, I get in the cold pool, I do all kind of crazy stuff just to kind of keep my body fat down. So yeah, a little bit of everything.
I love that. That's great. And there's a lot of descriptions on what you do in your podcast. Why did you decide to start a podcast? Why was that important to you?
Yeah. So, as I mentioned earlier, I really want to get the message out to my patients. And, I mentioned I have, a large number of patients right now in my panel. And I just felt like that because I only have 5 or 10 minutes with them, if I could just get my message out, and a podcast would be a good way to do that. So that was number one. Now, I don't know how many of them listen to my podcast, but I know there are some. And then number two, as I mentioned before, I really want to educate physicians. And now, again, I don't know how many physicians listen to my podcast. There may be none, but I really just want to get the message out there that there's other ways of doing things that are better for the patients. And again, it's once I discovered all this, it's kind of reinvigorated my career and my excitement about medicine that I can actually help people. And so I want other physicians to have that aha moment. And so I hope that there will be some that listen to my podcast that, just begin to, start researching on their own so that they can figure out a better way to go out practicing medicine.
I love that. You've brought this up a few times, but I can tell there's a sense of passion and joy that comes from actually being able to do what you set out to do in the beginning, which is help people. And I love that. I love that it sounds like you wake up and you're excited to go to work every single day because you're going to be able to help people. You're creating this podcast that helps people, and people are listening, and doctors will listen, and this is how we change it. This is what we need to do. And so I really love and respect that you have done that. Besides the interview with your wife, which we know is your favorite for sure, what has been your favorite podcast interview that you've done so far?
Oh man. I really enjoy talking about health and fitness. And so I've enjoyed talking, to all these kind of experts in the field. Probably Dr. Bickman was one of my favorites, just the research that he does and, his take on high insulin levels. And most of us think about insulin levels just as it relates to diabetes, but how this chronic high insulin levels leads to so many other chronic diseases, Alzheimer's disease, arthritis, and all those things. And so I think his research is fascinating, and that's probably been one of my favorites.
I agree. He's such a good dude. I'm so grateful for him and his work, and that both of us were able to capture his message. I'm so glad also, I told you this before we did this interview, I'm so glad that you talked to him about immunity, especially in 2020 where everybody's so concerned about immunity. That was a wonderful interview, and it was cool. He talked about the mechanisms behind insulin resistance and immunity, not just the comorbidities that associate with immunity. And so I really love that interview, and I'm glad you went there with him. Any teases for the future? Any guests you've got lined up that you're super excited about?
Let me see. I'm getting ready to talk to somebody about some wearables. Matter of fact, it's Whoop.
Oh, I was just researching that. That's cool.
Yeah, and so it can give you some data, actual quantifiable data to see like how well you're sleeping. I've actually got one on right now, but and it breaks down your sleep, like the amount of REM sleep, the amount of deep sleep. It also tracks something called heart rate variability, which has been shown to kind of be a sign of overall health and readiness, and so how hard you should work out that day. So it gives you some interesting data on yourself, and so I've got that coming up. And
awesome.
I'm going to have one coming up on, I briefly mentioned cholesterol, and that's a whole big topic. And so I'm going to have an expert cardiologist, talk about cholesterol and dispel a lot of the common myths about cholesterol. Because a lot of people, that's their first question when I advocate this higher fat type of a diet. They're like, well, what about my cholesterol?
Yep.
And, I'll usually say, well, what about your cholesterol?
Yeah.
But that's a whole nother topic. So.
Wow. I love that. That's great. We'll look forward to those. We've already shared a few guests. We've got Jen Stevens lined up as well.
Oh, cool. Yeah, she's great.
Yeah, I'm super excited for that. That's going to be great. What makes you optimistic about the future? We've had a pretty tumultuous year. What makes you excited for where we go from here? Yeah.
Well, people like like you that are getting the word out about getting people healthy. I think that if nothing else, this pandemic that we've been in has made people realize how unhealthy this country is. And they should have known that before, but it's really been kind of a black eye and, in that realization. And so I'm hoping that the message that we're getting out there is going to make people just think more about their health, and that's really how we're going to beat a pandemic, is to get our society healthier. And so that's what I'm hopeful for. That's what I'm going to keep preaching, that message is let's get everybody healthier. And then not to diminish, COVID and all that, but if we get everybody healthier, then it's not quite as big of a deal.
I love that. I love that people like you are sharing your message. It's something that you had to go out and pursue yourself. It's something that you had to study yourself, but you didn't keep it to yourself, and you're actively sharing it with your patients, and you're sharing it on your podcast, and it's making a difference. And you're right. This is where we have to start. And so I really appreciate you and your work and everything that you bring into the table. It's really great.
Yeah. And I appreciate that. And I'd really like to encourage people to, do their own research. And, when you go to your doctor now, listen, doctors aren't bad people, and they're well-meaning, and they're just doing what they were taught as far as, if they're prescribing you medicines. I mean, that's just what they're taught. Again, they're well-meaning, but do your own research. You don't have to take everything your doctor says as gospel. It's your body. And so, just research it and do what's best for your own body is what I would say.
That's fantastic advice. We always ask our guests to leave the listener with one simple thing that they can plug and play into their lives right now. Is that the thing that you would recommend to them? One simple takeaway?
Yeah, I asked the same thing on my podcast. And yes, I would say, and I would just go a little bit further on that is, and listen, I'm a doctor saying this, but I think too many people rely on the healthcare system to make them better. And I will say that the healthcare system is not set up to make you healthier. The healthcare system is set up to make money. It's a money-making machine. And so I want people, don't rely on your doctor to make you healthy. Now, they can be a coach and they can hopefully guide you in the right direction. Just somebody like myself who says, look, you need to start eating this way, you need to start fasting, you need to do this. But I think too many people rely on doctors, and they think that medicines are going to cure them, and rarely is that the case. And so don't rely so much on medicine and your doctors, but start thinking a different way and do your own research, and realize that most of the time the answer is not in healthcare, but it's in just wellness and all the things that we've been talking about.
I love that. That's great advice. Where can people go if they want to connect with you?
Yeah. So, as you mentioned, my podcast is FitRx, FITRX, with Dr. Greg Dennis. And, we talk all about health and wellness. If you are in the Oklahoma area, my clinic, my wife is there now, and I'm going to be there shortly, is Vibrant Life. We talked a little bit about direct primary care. That website is Vibrant Life DC, as it stands for direct care. So vibrantlifedc.com. Or you can email me, Dr. Greg at vibrantlifedc.com. And yeah, that's it.
That's awesome. Well, like we said, Dr. Dennis, thank you so much for your time today. Thank you so much for doing the research that you've done and being willing to share that with us today, with your patients, with your podcast, and everything that you bring to the table. It's really necessary and needed, and we're really grateful for you and your work.
Oh, thank you very much. It was a pleasure to be here.
Awesome. And this has been another episode of Boundless